Okay, good evening, everybody. So we will talk about population health management and, above all, the social determinant of health. So, Bertrand.
So I'm Bertrand de Neuville. I'm director of digital and data within HEVA. HEVA is a CRO, a French CRO. And first, thanks, because we are not that much. It's at the end of the day, so I'm sure that you're very interested by the population health management, and I hope you will have some questions and we can have some interesting exchange.
And I'm Christophe Clement-Cottuz. I manage a work group within the French association called Numem. And we think about what might be the future of the health system and taking care of the population and not only the patients. And this is why we will be talking about the social determinant of health. So, and the title of the intervention is Leverage Social Determinant of Health. So, the aim of most of the authorities and health organizations is how to assess the wealth. And the question is, as we in the future will see that need in care is growing and exponentially growing, and we have medical and care resources which is at least stable, and how we can achieve we need to assess the health of the population, and in order to be able to focus on some risk and signal we see in the data, we'll say that, and detect and facilitate the immediate response to emerging, especially the environmental crisis. So what are the social determinants of health? If we look at the health of how to modelize the health status of a population or a person, that we know is that the healthcare data are not enough. And according the World Health Organization, it's only 20–25% of the health in the sense of OMSG terms is taking care of the well-being and the mental health and everything which is according to a person. So what this is that the health data is only 25%. So biological and genetic factors are 15%, but the social determinants of health are 60%. So what we need to understand is what are these data and in which way they influence the health of the population and the people. And at least, and at the end of the day, the main objective is to how to manage the life, the good health life expectancy of the people instead of the level of disease in the systems. So the definition of the social determinant of health is the condition in which people are born, grow, work, live, and age. It means that we are to take care about all the data which are outside the healthcare systems and the social determinants and how the people live and what are the addiction and so on. And this is what we need to take in consideration, and we have 7 main domains of the social determinants, the social and community context. It means that, for instance, in London, it is said that when you take the tube at each station, you have a life expectancy. This is reducing by 1 or 2 years by station. So it means that this kind of information we need to. The economic stability, the revenue of the people, the neighborhood and built environment, what is the kind of housing you have and what is the quality of the quality, health and care access, do we have access to the care? And in France, it's the main aim of the French Ministry of Health, the care access. And also the education, and the level of education is probably one of the main burden we have to solve, because if we look, for instance, at nutrition, and nutrition, the education is the first level we have to handle for that. So manage the aim of population health management. So what we need to understand, what are the social risks, and by social risk, for instance, we had in France Gilets jaunes, and it's kind of social risk that we might trigger with if we don't consider the social determinant of health, the social needs. And for instance, if we want to target what we call the people which is under poverty, for instance, and in France we have between 9 and 11 million people living at the threshold of poverty or under this threshold, and the health disparity, and we are talking about medical desert, so we have to understand that to find out or to determine what kind of action we have to take in a territory. So what we need to achieve, health equity, it means that it's not equality, it's equity is all people, whatever is their condition, are able to access a good health, not care, but at least good health. And if we know what we know, if we want to achieve that, we have to change the organization. And it's not only the hospitals, the physicians. And if we want to achieve this, we have to integrate more people in the loop. And for instance, the social services, the association, and many people in each territory, depending on the risk we want to handle. And this is what we have to create. And to create that, we need to first determine what kind of leadership has to be made. Either it's the hospital or the local authorities or other companies. So we don't know yet, but this kind of thing we have to think about. And it's out of scope today. And fortunately, we have to think about a new economic models, because we can't continue with what we are today. So now the question is for you, Bertrand. You are a company specialized in data and handle data, analyze data. So what do you have today at HEVA in terms of healthcare data?
Thanks. So basically that's it. It's what I want to discuss with you is first, what are these social data? How can we access it? What can we do with it? And how could we improve any studies to better leverage this kind of data? I think we can go on the next slide already. Before even to speak about social data, the question that we have is that there are a lot of health data that have been already collected, but they are quite hardly accessible, and they are very little interconnected. So it's what we developed a platform called Agoria Sauté that we developed with AstraZeneca, Takeda, and Impact Healthcare. And the target of this platform is to accelerate and facilitate data access. As you see today, we start with claims data. We added some clinical data, clinical studies data. We are adding more and more data coming from the care. What we don't have here, and what we don't have even within the database from the care, is social data. And that's one of the targets, is that tomorrow we are able to add this kind of data that are quite hardly accessible. One point, I guess you saw it, it's the small logo on the left, is that we are part of the La Poste group, so with all the postmen, nothing to do with health, so we are a very specific business unit for health, but what we can leverage is the postmen. And postmen, we have like 60,000 postmen all over the France, and already we are already leveraging them to collect data. It's more for the silver economy at this stage, but we have postmen going to the people, first giving them some information about prevention, but then asking them questions on the loneliness, on their needs, for instance, for the housekeeping, how they can move within the home, about if they are unemployed or not, if there are any functional vulnerabilities. And it's not only question. We have also experts that can go at home and do some assessments on these vulnerabilities. And all these are social data that we target to add in this kind of databases in the future. Yeah, I mean, basically, what I wanted to share also here is that there are a lot of studies showing that depending on your social determinants, you won't have the same care pathway. We are not equal to the access to innovation. And so basically, this is a study that we have done a few years ago with BMS, where the objective was to assess for if, depending on the rurality or the level of how you're differized, if you have the same access to the diagnosis, and if you have the same, and consequently, to have the same chance and basically the same survival rates after 1 year. And basically, what has been shown is that clearly, if you're in rural zone, you have less chance to be, or you're diagnosed later. And if you are in some area where you have mostly people that are differized, your survival rate is lower than in other area. So now the question is, first we have done this study, and I will explain which kind of data are accessible, but how can we access this data, and how could we improve this kind of analysis?
You have great experience in healthcare data, and the question is, today, if you have to build a new data model which includes all the social determinant of health, what is the gap you have to fill to achieve that? And is it something which is impossible, possible, and what is the issue with that?
I mean, first, with the existing database, we have very little, if any, social data. So where we may find some is from the claims data coming from the health insurance, where we have some information about the low income, because we know there are some specific right for the health insurance, or about illegal immigrants with the AME. So it's at the personal stage, we have very little social data. But still, we can do a lot based on the residence data and using open data coming from INSEE, DRES, or other public institution. And basically, we can have information about the rurality, about the social deprivation index, so those two were used in the previous study, based on the unemployment, the median income, the education level. There are also some index about the primary care accessibility, so basically, how long do you have to wait, and how hard is to access some GPs, for instance, and also is how you are confronted to some kind of pollution, water, noise, air quality. All this is still at the zip code, basically, on the regional space, so we don't have data specific to each people, but actually it's already very good insights to see to extrapolate some social determinants.
That means it's possible. So
yeah, that means it's possible. And today, what we could do is that these data, they are existing. If you look from the pension, the unemployment database, about the social aids, there are these data sets. It's just that they are not linked with health data. And tomorrow, that we will get, that we have at the people level some social determinants.
So the last point I wanted to raise with you is data to manage collaboration, because we talked about before about the new organization we have to put in place to manage health of population, and you had a word about your postman and the 10,000 of postmen you have within the post. So the question is now, what kind of people we have to make to put in collaboration within people in one territory? And it seems it's many people we have to do that. And is that something you have in your offer, and how to represent and to to distribute the data and the report to the people acting and people which are not working together today and will have to work together tomorrow and share the same information.
So on this, I think we have to be very modest. If you want to transform this, it's all the organization that we have to rethink. It's always also how you refund all this. What we do at this stage is that all this data we can easily provide some dashboard based on all these social determinants. And actually, it's also when you work on some specific operation that you can also then deploy some specific help and a specific care organization. So it's what we have today. So we are able to do some kind of business intelligence. Then it's all the organization that has to be rethink to see how we can offer some specific services to people that need the most.
Thank you. So we didn't talk about AI, but you can understand that we want to make the correlation between all this kind of data, medical and social data. We need AI to perform that. So thank you for your attendance.